Hey, assalamu alaikum everyone. So I just wanted to do my second lecture tonight as well. This is going to be on the salivary glands and the mandible. Um, some of this stuff, like I said, is covered in pathoma. Some of it's not, but it's all important, and I'm going to be going through it. All right, so we'll start with salivary glands. So this is just some quick anatomy that I think is important. The parotid gland secretes most of the saliva for when you're eating. Okay, and the submandibular gland secretes the saliva that keeps your mouth nice and moist when you're not eating. So it's kind of like the baseline. So people who have chronic dry mouth think submandibular, or people who just have difficulty producing saliva when they're eating, think parotid. Also important in this and then sublingual glands are also important. And also that's important in this diagram is the facial nerve because we're going to talk about this quite often as we're talking about the parotid gland, but it's important to know that the facial nerve goes through the parotid gland. So sometimes malignancies, especially the ones that are very aggressive, can affect the facial nerve. Okay, so let's talk about xerostomia. Xerostomia, I don't even know if I'm always saying that correctly, depending on the country. It's got a different pronunciation, but basically, xerostomia means dry mouth. That's pretty much all it means because you don't have as much saliva. And that can be caused by a lot of things. This usually, when you think of this, you think of older people, 70 years of age or older. Um, Sometimes it can be autoimmune, like Sjogren's syndrome, which we talked about in the past. But the most common cause is medications. So think, your old people that are on tons of medications, some that are like anticholinergics or analgesics, or they're on muscle relaxers or sedatives, or they're on antihypertensives. All those medications can cause you to have a dry mouth. So a lot of times, unfortunately, this is iatrogenic, meaning it's caused by us, and it affects older people because they're the most likely, especially on who are going to be on those medications. And so dry mouth can also, causes obviously to have dry mucosa. You can have atrophy of the papillae of the tongue with fissuring, ulcerations. Um, and then also, if you have Sjogren's syndrome that's causing dry mouth, you're going to have an inflammatory enlargement of the salivary glands. So, yeah. And then also some complications that result from dry mouth that you don't always think about is that you're more likely to have dental caries, which we talked about in the previous lecture, oral candidiasis, which we also talked about, dysphagia, because obviously it makes sense, right? You don't have enough saliva, it's hard to swallow, and it's tough to speak. That's why whenever if you're at a concert or you hear singers, they're also always drinking water because their mouth gets dry, and they need to replace that. So sialadenitis. So let's break that word down. That's why I have it underlined right at the top. Sial means salivary, aden, gland, itis, inflammation. So inflammation of the salivary gland, sialadenitis. It can be caused by trauma, viral or bacterial infections, or autoimmune diseases. So let's talk about some of the common causes that are important to us. Um, so mumps. Mumps will come up quite often. It's very common, especially in places where people don't have adequate access to vaccinations. It's a very common viral cause. Um, it can produce enlargement of all the salivary glands, but predominantly involves the parotids. Classically, it's taught as bilateral enlargement of the bilateral parotid glands. However, sometimes, most of the time, it's unilateral. So, but it can be bilateral depending on how often it is. But classically, on board questions, they may say bilateral. Um, it also has interstitial inflammation marked by a mononuclear inflammatory infiltrate. So if you see a biopsy, I'd expect you to kind of know what that looks like. In children, it's most often a self-limited benign condition. In adults, it can cause pancreatitis or orchitis, and if it does cause orchitis as you get older, it can cause sterility. Um, but we'll go over mumps a little bit further here too. So, an mucocele is the most common inflammatory lesion of the salivary gland. It's due to a blockage or rupture of the salivary duct with leakage of the saliva into the surrounding connective tissue stroma. So it's almost like a saliva builds up in your lower lip and then it just explodes, but it just stays within your lip because it doesn't leak out. So you get basically a swelling of the lower lip that changes the size, and it's associated with meals because remember a lot of saliva is triggered as you're hungry, as you're eating. Um, Histological examination, cyst-like space lined by granulation tissue. and definitive treatment is excision of the cyst. Um, and then you have sialolithiasis with plus or minus with bacterial sialoadenitis. So sialolithiasis, let's break that word down again. Sialo, salivary gland, lithiasis. Lithiasis, basically means stone. When so first off, so a lot of these people, if you look at their ducts, they'll have a stone that's stuck in there, and it could be impacted by food debris or edema, consequently as well, and then you can have retrograde infection. And I want to explain that concept a little bit because it's going to come up again when you talk about kidney stones as well. So any kind of stone or any kind of blockage, let's say between, let's say, the kidney and the bladder, right? Let's say you have a kidney stone and it blocks that space. When fluid stops moving, that's supposed to be moving, it creates infection. And the reason, another example I want you to remember is, like, let's say you have a river, right? And the water is running. Usually the water is less polluted. But when you have a puddle on the ground with stagnant water that has not moved, that water gets dirty, bacteria start to grow, things like that. Same thing happens in your body, right? So let's say you have a gland, your parotid gland, and suddenly, a stone forms for a lot of reasons in the duct. Then suddenly the gland gets really big and big and big, swells up with a lot of mucus that's not being used. The mucus is stagnant, it doesn't move, then you get an infection, usually Staph aureus. All right, and then Sjogren's syndrome, which we also talked about, that's also a cause of sialadenitis. So mumps, bilateral parotitis could be unilateral, pancreatic. In pathoma, he mentions the elevated amylase from both salivary glands and pancreas. But remember, to confirm that's pancreatic involvement, you should obtain a lipase, right? So if the amylase is elevated in a patient, it could be because they have pancreatitis or an inflammation of the salivary glands. Both release amylase, but um, pancreas is the only thing that generally releases lipase. So that's how you distinguish. So make sure you order both. Orchitis, like I said, can cause sterility in teenagers. And then another dreaded complication is aseptic meningitis, where you get inflammation of the meninges that surrounds the brain tissue. Thankfully, again, since we've had immunizations now, this disease has gone down, but you still see it pop up here and there. Mucocele is, I talked about this. This is what it looks like on the lower lip. Please look at that histological slide on your own and make sure you know what it looks like. Salolithiasis, again, this is the stone that gets stuck in the duct. Um, I see textbooks, oftentimes are written by, God bless them, academics, but in practicality, very few people actually go to the operating room to have this surgically removed or actually have the whole stone removed by removing the, whole salivary gland. Okay. Most of the time somebody comes in, they'll tell me clinically, "Hey doc, I was chewing food and suddenly, boom, this gland blew up," or "Boom, I suddenly felt pain under the tongue." And you look and you're like, wow, your gland is inflamed. And they'll usually say it was a very acute, very fast, usually when they're eating. And a lot of times, oftentimes, you'll see the stone. So look, if you look on this top photo, you see that stone. I'm not going to send that patient to the OR. What I'm going to do is I'm going to give them a sialagogue. A sialagogue is anything that you can eat that makes you have more saliva. So if you eat a sour candy, um, it makes you salivate. So, you know, I go tell somebody, hey, go to the candy store, get a sour candy, make sure they suck on it, and make silagogue. I also put compresses, I also massage it. And more often than not, I'm able to get this stone out so, it doesn't develop any complications. If I can get the stone out, then, they don't need any antibiotics a lot of times and they don't develop any infection. But if I need to admit them because I can't get the stone out, or I need to call an ENT surgeon to get the stone out, well, oftentimes I'll start them on antibiotics because, like I said, they might develop a Staph aureus infection. All right, so let's now talk about the benign and malignant salivary gland tumors. The ones that are circled are the only ones we're going to talk about. And I just want you to appreciate that even though you're studying pathology, you're not studying every single thing about every single gland, right? It would just take forever. And so we just kind of go over the big stuff. I also have an arrow that I drew on this chart. You'll see pleomorphic adenoma, and you'll see an arrow going to adenocarcinoma. Even though pleomorphic adenoma is benign, it can lead to adenocarcinoma, which I'll talk about here in a second. So this is, very nicely taught in pathoma as well. So I'm going to go over it very quickly. But it's basically a benign tumor of the salivary glands, right? It's a mixture of ductal epithelial and myoepithelial cells, so they exhibit both epithelial and mesenchymal differentiation. It's a pleomorphic adenoma. So if you look back at your pathoma book, you'll see what it looks like in one of the pages. But basically, it has a very irregular shape. It has very different differentiation. And so when it's removed, it has to be removed in its entirety. If it's accidentally not removed in its entirety, which is very often, then it tends to recur. And unfortunately, if once in a while, these can become um, uh, you can get a carcinoma that arises from it that's very malignant. And if it does, it usually turns into an adenocarcinoma or an undifferentiated carcinoma, and has a very high mortality rate. And and again, since it's a malignant, involves oftentimes involves the parotid gland. You're going to get facial nerve damage, as because the facial nerve kind of goes through that area. And again, I want you to remember, I've kept saying that anything malignant in the mouth or the oral cavity usually has a high mortality rate because possibly just a lot of times just poor detection. People aren't looking for it. Warthin tumor, this is a benign cystic tumor. I think it's covered adequately in pathoma, but I wanted you to have this slide to show you what it looks like. You have a dense lymphoid stroma and um, a nice layer of epithelium. It's the second most common tumor of the salivary glands, and again, it's mostly in the parotid. Mucoepidermoid carcinoma, most common malignant tumor of the salivary glands, usually involves the facial nerve. So this is a malignant tumor, um, and unfortunately, sometimes it can have a poor prognosis as well. Now let's talk about odontogenic. Odontogenic meaning the jaw. Okay, so the mandible. Um, I probably should have put this section up with the teeth, but it deserves its own merit because it's something that you don't always think about. It's not very common, except for one of the things that we'll talk about. But it's something that if you see it, and you know what it is. So these cysts and tumors, they're classified as either inflammatory, meaning occur later in life, or developmental. So they usually occur earlier in life, and you'll see them, or they'll grow from some embryonic remnant, or a failure of the tooth to erupt. So let's start with dentigerous cyst. It's a developmental cyst that originates around the crown of an unerupted tooth and is thought to be the result of degeneration of the dental follicle. Um, so basically, the tooth just doesn't come out. It stays inside, does not come out. And a lot of times, these are these are your wisdom teeth that are in your back, um, and complete removal is curative. And so that's why oftentimes, if you have unerupted tooth in your back of your teeth called your wisdom tooth, oftentimes the dentist may offer to remove them. And again, this is probably, this progressing and getting worse is probably more common in areas where people don't have access to adequate dental care. Odontogenic keratocytes. These are, again, developmental cysts that are typically located within the posterior mandible. So you can see this blackish area in the back of the mandible. Um, these, unfortunately, are very aggressive, have a high recurrence rate. I'll let you read kind of the histological description, but it's parakeratized or orthokeratized stratified squamous epithelium with a prominent basal layer and corrugated luminal epithelial surface. I don't think you're going to have to remember all that, but just know where it's located and the fact that it's very aggressive, and it recurs very often, again, with inadequate resection. Periapical cyst, or sometimes also, it's called periapical abscess because that's what it can lead to. This is something I've seen all the time. It's very common. This is basically if you have a cavity or dental caries and you don't get it fixed, or you get a really bad trauma to your teeth. It can lead this, uh, as a result of those things cause pulpitis, and if you have pulpitis, which is inflammation of your of excuse me, that can lead to this area that you see on the right. And once you have a periapical abscess, unfortunately, you need to see a dentist and talk about having your tooth extracted, or at the very least some form of debridement. Again, I'm not a dentist, but I can tell you that if you see this on an X-ray, if you suspect it, a lot of times what I'll do is if I push down on the tooth, and people are like, "Ow, ow, ow." I'll suspect it, and then I may order an X-ray to confirm. Um, now 9 times out of 10, inside of a regular hospital that doesn't have dental specialists, you're not going to get always get the right films. But if you see this hypoechoic or this blackened area around the base of the tooth, that's very suggestive. And last thing, quickly, I'll just touch on odontogenic tumors. I just want you to know that they exist. These are basically tumors of the mandible. Or the teeth involved, sorry, as well. So odontoma, that's the most common type of tumor in this area. It arises from epithelium. It shows extensive deposition of enamel and dentin, and the treatment is local excision. And basically, to me, it just looks like a clump of teeth, and those are usually removed in young adolescents or children. Amelioblastoma, that's the other common one. It's slow growing. Sorry, I shouldn't say it's common, but it's slow growing and it's locally invasive, and people get extremely, extremely deformed from this, as you can see that gentleman in that photo. All right, guys. So this concludes my section on chapter 2.